Tonight, we're going to talk about non-unions of the femur and how to get it right the first time. There's a lot of intricate tips and tricks that go into diagnosing non-unions, and my co-faculty are here to support us and taking us through this delivery of information. So I'm going to go ahead and let them introduce themselves.
Hi, good evening. Mitchell Bernstein from Montreal, Quebec. It's a pleasure to be here with these amazing group of people. I am a orthopedic trauma surgeon, both in adults and kids, and I also fix bones that are infected, short, and crooked.
I'm Steve Warner from UT Houston as well. Looking forward to a fantastic hour plus to discuss this topic. So definitely appreciate the opportunity to be a part of it.
Excellent. Thanks, guys. Well, just for the sake of completion, I'd like to say that AO North America is an independent, not-for-profit surgical specialty society dedicated to improving the care of patients with musculoskeletal injuries. We do not endorse nor promote the use of any products of commercial entities, and things that you see in this webinar, implants, equipment, etc., is for demonstration and teaching purposes only, with the intent to enhance your learning experience. So tonight we're going to talk about techniques to evaluate femoral shaft non-unions and how to choose effective treatment strategies. It's going to be a case-based format where we will share some victories, but also some losses. And sometimes those tough cases are the ones where you actually learn the most. At the end of this session tonight, hopefully you'll be able to better understand current techniques.
My hand was raised. My hand was raised. I guess you didn't see it.
Oh, I did not see it.
I don't have any losses tonight. I'm only presenting wins. I just want to clarify that for the audience, for the expectation management.
But do you ever actually have any losses? I mean, I was
talking
more about myself.
A lot of losses.
Let's talk about the importance of preoperative evaluation of non-union, describe effective treatment modalities for femoral shaft non-unions, and understand some operative tips, tricks, and techniques to improve your outcomes for femoral shaft non-unions. So here's a quick overview. We're going to try to get through as many cases as we can. I'm going to do a quickie, followed by Mitchell with a couple, followed by Stephen with a couple. And if we have time, we've got a couple more to round out the session. So let's dive right in. Thanks everybody for being here. Let's get after it. So case one. This is a 68-year-old that was referred to my office 1.5 years after a car accident. He's currently 1 year status post an exchange nail of his femur. The nail size, you'll note, was a 15 by 420. And he has persistent complaints of pain in his thigh and in his knee. So here are his X-rays. So I'll give you a moment to take this in. You can see a large diameter nail, retrograde in nature, 2 distal interlocking bolts, 1 proximal interlocking bolt. Relatively hypertrophic, especially on the lateral. You see abundant bone forming proximally. So these were the images that I started with. A lot of times it seems fairly consistent that lots of orthopedic trauma surgeons get CAT scans to ensure that we've gone from a multi-fragmentary fracture plane down to a single plane of non-union. Mitch, do you get CAT scans for all non-unions?
No, I mean, if you go back one slide, my first thought, if you were going to ask me, because I was nervous you were going to ask me in front of everyone, was, is this, because I also want to be real, is this actually not healed? So if the patient has a lot of pain, notwithstanding any hardware failure, obviously, then yeah, I would pursue a CT scan to confirm that it's a non-union. Especially with a lot of fracture lines that seem to be bridged, distally, posteriorly, distally, anteriorly, in the mid anterior. There's might be a posterior fracture line in the middle image over here. There's testing of this annotation tool. So yeah, I'd get a CT here.
Yeah, those are my thoughts as well. And a lot of times when a new patient is referred, it's easy to just say, oh, clear, they were referred for a non-union. But sometimes you can be surprised at the amount of so-called spot welding that's occurred through different areas of the non-union or the fracture. And I don't know that anyone has an exact answer of, sometimes your radiologist will come back with like 80% union or some numbers that they're coming up with. I don't know that each individual patient has an exact number that they have to have 78% union before their pain goes away. But in fact, that's a common thing that we see around here. At any rate, you can see clearly this patient continues to have a non-united fracture. At this point, it is pretty easy to kind of dive right in. It's fun to start talking about treatment options. But let me just take a subtle detour to talk about perhaps why this happened in the first place. We know that not all fractures are created equal, and there's a lot of different factors that go into the energy of the injury, the host, whether or not the joints are involved, which part of the bone is involved. We know that in non-union, typically it's an issue of biology and or stability, and oftentimes biomechanics. At any rate, something is wrong. So it's really up to us to diagnose exactly what it was that was wrong, rather than just dive right in with discussions about, okay, what do we do now? I don't mean to insult any of the folks on the call, but we know it's a race between the fracture healing and the metal failing, and sooner or later, if the biomechanics are not right, implant failure ensues. Again, I'm sure most of the fellows on the call have seen these types of Venn diagrams. This is one that I've been using for years in a way that I can draw out in the patient's room and try to describe when someone says, "Doc, why did this happen? Like, I loved my surgeon. I love you. Why didn't it heal?" But we know there's some patient factors that go into it, whether it's comorbidities such as diabetes, obesity, maybe they're heavy smokers, maybe they're non-compliant. We know there are injury-related factors. How open was the wound? How much periosteal stripping was there? Is there bone loss? And then we know that as surgeons, there are things that we are in control of as well, such as assaulting the bone with perhaps too many screws or cerclage wires, or maybe even making incisions that are too close together. Ultimately, it's nice to try to classify these fractures. And again, the fellows have seen these for years, different types of non-unions. And you might say, well, yeah, I know, I get all that, but who really cares? Why does it matter what type of non-union it is? Well, the reality is it's because the classification guides treatment. And for years, this is really the way that most orthopedic trauma surgeons have been thinking about non-unions. I know that a lot of diaphyseal lower extremity non-unions get exchange nailed. I know that. But the reason that we're doing trauma fellowships and trying to work a little bit harder to get it right the first time is to use our brains and not just exchange nail everything right off the bat. You'll notice that stability is a recurring theme, no matter what type of non-union it is. But one thing that I think folks don't focus on so much is the alignment of the lower extremities. In particular, the alignment is critical. And if your alignment is not right, you can exchange nail till the cows come home. You may not have success. Just for completeness sake, this is an article that was written back in 2016 in the British JBJS, and this is a really interesting read. I think all trauma fellows should have this in their library. The Unified Theory of Bone Healing and Non-Union, where this group out of Nottingham talks about how the mechanical environment is really the most critical portion of the etiology of non-union. And in fact, the lead author, Dave Elliott, I've seen him give many talks on how he will never bone graft any non-unions. And in fact, if you can get the stability correct, there's really no need for the donor site morbidity of an autograft harvest, etc. At any rate, we don't want to go in too far into the weeds here, but this is absolutely worth your read if you're a trauma fellow that's logged on and you haven't read this paper. So that being said, back to our case. What type of issues do we have? Well, anytime I have a recalcitrant, twice operated long bone, infection has to cross your mind. You're going to get the standard inflammatory labs, but also use just clinical clues. Was this ever infected in the past? Is there a draining sinus? In this instance, this patient had no stigmata of infection. I think sometimes when these are your own cases, it's easy to say, this alignment's pretty good here. This looks pretty good. When it's other people's cases, it's easy to throw stones and say, oh my gosh, look at all the varus. But in reality, even with a little bit of varus, I think probably this is hypertrophic. This is trying to heal. But in a case that's already been reoperated, I think the varus is absolutely a problem. And again, it's hypertrophic. It's biologically active. So this should be a relatively straightforward non-union to get to heal. But let me ask Dr. Warner, what are your thoughts? Recalcitrant non-union, if we're going to try to get it right the first time, where do you want to go?
I think taking the patient's history into account is really critical. They've already had a exchange nail attempt with a large diameter nail, and so that's an important part of that history, and something that you can get caught doing is trying the same thing over and over again and expecting a different result. And so I think with these cases with a history of previously attempted non-union repairs, I think it's worthy of a discussion with the patient of trying something new as opposed to something that may not have worked in the past. So certainly this is tempting to try another exchange nail with the correction of alignment, but nonetheless, this patient has been dealing with this non-union, which we know is a significant disability for a year and a half, and has already had one surgery to try to repair it. So I think a more invasive surgery is going up that ladder of invasiveness for trying to repair this non-union would be something that I would present to the patient. A lot these discussions can be in-depth, and these can be very lengthy discussions in clinic, but for this, I would think something to increase stability, improve alignment with the exchange nail and augmentated plating with some autograft of some sort, potentially using RIA of the ipsilateral femur would be probably one solution.
Mitch, I've seen you on the podium. I know you are passionate about lower extremity alignment. How are you going to improve the alignment of this femur?
First, analyzing it properly, I would say. So standing hip to ankle X-rays to check coronal alignment. You can check sagittal alignment, and then rotation. Probably wouldn't implicate into a non-union, but I probably would check that as well. But standing hip to ankle and looking at the mechanical axis. And Steve's comment is, when I was thinking about next step, I get very anxious with dynamization. I don't know when and how that works. I also get nervous with exchange nailings because I find it okay, but I'm nervous because I don't know if it'll work. And Steve's mentioning a lot of biological augments to this seemingly hypertrophic non-union, which I don't disagree with him. So I think what is challenging and interesting for us is finding out, I really like your points, Tim, finding out why this thing failed and making sure if you cite hypertrophic, say it very carefully, because then you really shouldn't be adding any biology. So it depends how much of an academic snob you are, or how accurate you are with your diagnosis.
Those are great points. And if this was the first time I was seeing this patient, I agree that probably a more conservative approach is appropriate. I mean, in most studies, hypertrophic diaphyseal non-unions have almost a 100% union rate in a well-aligned lower extremity that undergoes exchange nailing. So, but that's a well-aligned hypertrophic non-union. This femur is not necessarily well-aligned. So the question becomes, how then can you get it better aligned? Let me just show a quick different case. Here's a guy treated by one of my partners initially with a retrograde nail, young man in his 30s, ATV wreck. You can see he goes on to a hypertrophic distal third non-union with some subtle or not so subtle varus deformity, depending on how critical your eyes are. So here, after we take him to the OR, one of the things I like to do is just try to mobilize the non-union. Does it correct to where I want it? And if not, you know, when I was first in practice 15 years ago, this would have been a large open approach with a non-union takedown to mobilize the non-union to improve the alignment. But one of the tricks I've learned over the years, and I think I heard Mike Bumgardner give me this tip somewhere, small incision, and just using a 2.5 or a 3.2 millimeter drill, and you can just drill the non-union and pilfer it up in multiple layers along the path of the non-union. And then once again, try. Now is it mobilized? And if it's not, a slightly larger incision, now you can sneak a 1/4 inch or a 1/2 inch osteotome into the non-union. Again, just trying to mobilize it a bit. And usually, even stiff hypertrophic non-unions are amenable to mobilization with minimally invasive techniques. So you can take a varus aligned femur and with minimally invasive techniques and some blocking screws, get a much better overall coronal plane alignment. So that being said, this was my preoperative plan for this patient. I thought that if you're in the know, then you know that a 15 millimeter nail, whether antegrade or retrograde, is the largest nail that's offered on the market commercially. So we talked about getting perhaps a custom nail that was a couple sizes larger, and perhaps using the lost art of the Jude osteoperiosteal decortication technique, originally published in 1972. These guys looked at almost 1,000 non-unions where they bone grafted none of them, but rather used the technique of entering the non-union zone and using very sharp osteotomes to decorticate bone that still had periosteum and muscle attached, thus in effect really angering the bone and performing an autograft with live periosteal chips. So here is this patient, lateral subvastus approach, leaving the periosteum and scar tissue intact. And you can use a bovie, make an incision and inline down the lateral aspect of the femur. And here we are ultimately using a very sharp osteotome to elevate small osteoperiosteal fragments, anterior and posterior, as circumferential as you can get. Usually it's only about 180, maybe 270 degrees around the femur. But here again, 1/4 inch osteotome, and you can see we're leaving all that periosteum intact. A common technique is to go in and just strip the soft tissues and use a burr or a osteotome to really pedal up, to shingle up the cortex. I find this works very well and often obviates the need for utilizing any additional bone graft. So here are some of those osteoperiosteal fragments still attached to periosteum, anterior and posterior. Now using that same approach, we can redirect the guide wire. You can see here the image on the left. We really need to ream laterally. If we're going to try to correct the alignment, we can ream in a little bit of valgus using a ball spike. We can use a shoulder hook or a bone hook to drag the guide wire lateral, and use a trochanteric entry nail through a piriformis start site for the so-called trochiformis site of entry to start to affect bit more valgus and protect against that varus. Then we can contour a lateral plate and give it a wave and really recreate a lateral cortex, helping to tension the lateral cortex, and then close down all those periosteal fragments around the wave plate. Now we've got improved alignment. We've got a recreated lateral cortex, additional stability with the plate. And at 4 months, he's pain-free, mobilized, nearly completely healed. And there he is at his 1-year follow-up. So,
Tim, go back one slide, because I think I noticed something really interesting. Go back one more, really interesting and subtle. So I'm going to go over it in my slides, but your nail target is now aiming appropriately towards the medial tibial spine, which would suggest now you're in line with the anatomic axis. And not a critique at all, but a bit of a critique. The entry point for the previous nail was in the center of the notch, which is in fact, I guess in this case, potentially, if we believe the alignment was implicated in the non-union, potentially source of the malalignment.
yeah, definitely all great points. And one thing that I really kind of find myself talking about more and more for midshaft and proximal third femurs, retrograde nails that tend towards the greater trochanter when they head lateral, generally, not always, but generally, that lends itself to an acute or delayed varus deformity, depending on the competence of the medial cortex. So in this case, I think the surgeon had best of intentions with the retrograde nail. Unfortunately, I don't know that the changing of the nail was enough to overcome the varus malalignment. So just a good case to warm us up. But I think Dr. Bernstein, looking forward to seeing what you have to allow.
The plate contouring of that, would you call it a wave plate? Is that, or you just pre-contoured plate?
Yeah, so that's an interesting, I did call it a wave because of the shape. However, it was really more to accommodate his pre-existing callus formation. So
Yeah.
in the truest sense of the term, perhaps not a wave plate, because we weren't capturing additional bone graft under the plate. But I still think it served to help recreate a stable, tensioned lateral cortex that may have added some additional stability for that recalcitrant non-union.
I admire the contouring. That's hard to do. So I'm going to go over 2 cases, and don't discriminate by the age on the first one. She's an 84-year-old active golfer. Second patient, 54-year-old male, renal dialysis, 2 femoral non-unions. My talk is going to lean a little bit to what Tim mentioned before, which is alignment and its implications in non-union, as well as your ability to assess it preoperatively and fix it intraoperatively specifically. So, I mean, we all know this, but I like this as a picture of McGill, and I'm sure a lot of you have the same logo. So alignment is really the foundation of what we do. So I want to just put that out there again. In the femur, I like this because the femur is eccentrically loaded. I know we all know that, but I think we shouldn't forget it. I mean, Tim's case was effectively all about this. And there are 2 axes in the femur, the weight-bearing axis from the center of the hip to the center of the knee, which is the mechanical axis, and the anatomic axis is obviously down the canal. As it relates to a surgeon, your entry point and exit point, just like Tim said, should be in line with the anatomic axis if you're using that to get your femur straight. So I think that's a good background. So here's the first case, 84, very healthy, plus healthy. Golfer. She had a fracture in Barcelona. Her daughter works for the government. She was visiting there and she had surgery in Barcelona. She said the leg was crooked right after surgery, and she's back in Montreal, and she's obviously not pleased with her leg. Labs, Pretty normal. She has a bit of an extension contracture, big valgus deformity of the limb, but she's walking around on it. So here's the X-rays, and maybe I'll throw that out to Steve. What do you think now? I mean, our physical exam is done. What's going through your head, and what other imaging do you think you'd want to do here?
And Mitch, the other question I had before we get into this is getting your inflammatory marker. The question that often comes up is, what do you do with that information? Oftentimes you'll have one or two that are mildly positive, and does that change your approach for doing, for example, a single versus a two-stage approach for this? Hers were normal, so it kind of makes it a little bit easier, but let's say that more ambiguous situation where you have one or two that are mildly positive.
Yeah, I don't want to say I become nonchalant to infection, and I don't mean to be arrogant or cute. Typically, if the labs were done, it was done by like a resident who's working with me. I like forget to get them, because unless there's pus pouring out, it's infected, or the other option, it's rule out infection for me. And so I stage if it's, like Tim said, there's a history of infection, there's some perioperative complications for infection, and or there's stigmata of infection. Then I'm going for a staging. I do think there's reasonable common sense and evidence that the stability really helps with the infection treatment. And if there's a higher likelihood, I may move to some sort of antibiotic coated implant. And if not, I'll just go with regular implants. So that's sort of my treatment plan.
Yeah, I think for this one, you know, in terms of your problem lists, you have deformity. So I think in terms of preoperative planning for this, full length films with lower extremity alignment films would be useful. I think other considerations are the bone loss. She has some resorption of bone there. So think about ways that you may be able to treat that. Her history of a total knee arthroplasty, I think, factors in as well. And I think discussion with her about revision arthroplasty versus non-union repair is relevant. And then her hip surgery is also relevant in terms of being able to instrument the full canal of the femur. So certainly she's an active patient, which is great, but I think having that discussion about revision arthroplasty or non-union repair is important. Assuming she wants to move forward with non-union repair, and assuming you want to take that on, I think challenges will be the bone loss and bone cleavage, and making sure you achieve enough correction of your alignment with that bone loss.
Yeah, I mean, again, for me, I don't know about you guys, I don't know how to do a distal femur replacement. But again, back to the topic is, how do you fix this once, the first time? And at 84, just by the age, a distal femoral replacement is seemingly an attractive option. So that definitely comes into play. Logistics with my colleagues is I'll get one of my arthroplasty or oncology surgeons to see the patient with me, and we sort of have some arguments around it. I agree, Steve, with the problem list. Poor bone stock is an issue. Alignment, total knee is functioning well. And obviously, shout out to Dave Beret, mega valgus. Patient has mega valgus. I do like to comment on the ability, if you're doing redo ORIF, her tibial tray is perfect at 90 degrees. So any strategy to fix her femur, again, is not a 95-degree plate, etc. You know, we need to get her mechanical axis from 75 to 90. If the tibia is at 90 and the femur's at 90, then we can get her a straight leg. So that I do talk about that. Steve, you summarized it well, so I'll keep moving. But I think these are our options. Tim, any other points in terms of your treatment algorithm?
No, I mean, I agree with all of that. And I especially love your comment. I'm seeing it more and more on the other end of the femur with the 52-year-old femoral neck non-union. And as much as I love doing a valgus osteotomy, I do send them for a second opinion to an arthroplasty surgeon, just so that they're playing with the full deck. They're truly making an informed consent decision, which I think for this lady, as much as I would love to say, no way arthroplasty for this, I think it's a realistic option that she has to be talked to about for sure.
Yeah, yeah, yeah. I couldn't really find much literature for distal femur non-unions above a total knee. I found this article that I thought was relevant because they looked at distal femur arthroplasty for basically not oncology indications. And of course, you know, the authors are commenting that a distal femur replacement is appropriate indication in the setting of distal femur fractures, especially those with a non-union like this patient. I think though this last highlight is not necessarily true anymore, because I think the trauma surgeons were getting better with plating and nailing options that allow immediate weight bearing. So 27 patients in their study, 74% above a total knee, 41% complications, 100% had reoperation, and 3 had an above knee amputation. Just to give some of the complication spectrum with a distal femur replacement. And I try not to be arrogant to say, as trauma surgeons, we're so good at getting these non-unions to heal, but I thought that let me give it a one go with redo ORIF and see if I can get it done well. In terms of alignment, things that I'd ask everyone to reflect on is how, you know, you got to get this knee straight. How are you going to do that in the OR? What are your implants going to look like? How are you going to augment the bone stock, like Steven said? And you need to figure out how you're going to restore this MLD-FA to 90. So,
Mitch, I got to say, I really love that comment, because I think a lot of times our eyes go to the deformity, we see a non-union, and immediately, I think a lot of us, it's just in our DNA. You start thinking, blade plate, dual plate, nail plate combo. You start thinking implants. And while the implants are important, I would agree with you that all of those intraoperative techniques of how you're going to get there, we kind of forget about that sometimes. You're so focused on the implant application. You forget about the deformity correction and how challenging it can actually be sometimes.
we're all saying that though on this webinar, Tim. You know, we are in fact saying that, and I do agree the implants are not as exciting for me and for I think a lot of us on this webinar. We all love nails. We all can do the plates. You know, we can augment, we can do the decortication. It's a question of some of these more, I think, mechanical or alignment issues. So same thing, Tim, for you. I'm validating this is a mobile non-union. I want to check that out in the OR, just making sure that's mobile. Hardware removed, intraoperative culture, Steve. I do that for rule out infection. I didn't think it was infected. I chose a strut allograft in the IM canal as my bone augment. And then I'm using Synthes Tomofix distal femur large frag plate. I use it a lot, so I know how it sits on the distal femur. And I'm using locking screws, but I'm putting them in sort of like pushing the plate right on the condyle as if a conventional screw was used to make sure that sits perfectly. And then, you know, I really wish I had navigation, because then I can figure out these angles. You know, is that angle off the side plate going to drive a 90-degree MLDFA? So I'm relying a bit here on Synthes to drive this reduction. And that was my, you know, that was based on some of the pre-op templating with some of my CAD software. So conventional screw in the diaphysis, right? AO basics type concepts, and just drive the reduction home. And then I did a dual plating. So then I'm adding an in situ, totally locked we're not talking about the distal femur non-union with compliant fixation and far cortical locking. This is in situ plating for me. I don't want to alter the alignment anymore. And I'll just do some validation in the OR to see the alignment. So I like this because, the family was very happy, and that's her dancing on Valentine's Day this year with her husband. So I do think we need some a la carte treatment for the patients, and this one, thank God, worked out okay. Comments, Steve or Tim, critiques, or
You mentioned using a fibular strut as your, I'm not sure if you said the biologic augment, but do you really think
bone
that
stock? I think.
Okay,
I may have misspoke.
Yeah, because the dead bone makes me a little nervous for such a relatively atrophic non-union. But again, if you believe in the unified theory and the mechanoreceptors, if you get the alignment correct, so this is no additional autograft. This is just fibular strut and alignment.
Yeah.
Yeah, it's a beautiful case.
What I didn't like is the strut cracked during the realignment, and I really tried to put the strut in while the femur was straight, but it as it realigned, it cracked, and of course a dead bone that's cracked is a bit stupid. but I just like full disclosure for everyone about that. So I'm going to move on for the sake of time. Is that okay, Tim?
Yeah, it's a great case.
Okay. So I like this case because you can't really do much about his biology. And I think that Venn diagram that Tim showed at the beginning is really important. 54, kidney transplant from diabetes, already had a cabbage. We've had a lot of these patients, they fall effing at the hospital. This guy falls, I think, after his dialysis from the hospital. I feel badly. So he has the huge, right? He has a closed reduction and cephomedullary nail. These are the intraoperative Xrays that the other surgeons got. And then this is 3 months, increasing pain, right thigh. I have an arrow for you to show you the nail is broken. We're not gonna tease that out. The nail is broken at 3 months. What concerns do you have? Why did this fail? Can you improve this, and how can you improve this?
Mitch, I have a question regarding the patient's comorbidities. A question came up in the Q&A panel about patients with a smoking history or tobacco use history. And a patient like this, obviously they have uncontrollable risk factors, but patients with risk factors that are controllable, such as smoking, does that influence your treatment algorithm with them? And are you testing nicotine levels, for example, and holding off treatment until they're appropriate, or are you forging ahead no matter what?
I'm forging ahead on a femoral non-union unless it's quite stable. If the implants aren't failed, if the implants are failed, I'm forging ahead. If it's something catastrophic, I'm forging ahead. But if it's pretty stable, or if it's not a high risk area like a humeral non-union, no, I would try to optimize that. And I think that's almost like a webinar in and of itself.
Yeah, agreed. I think that while I would love all of my patients to be optimized and quit smoking, etc.,
Right.
if I waited for every patient to stop smoking, I would not have a non-union practice.
But then also, Tim, it becomes your problem, right? Like if you're going to deal with it, so unless you're not, right? But I know the three of us are, so it's a bit selfish, right? Like,
well, let me just ask you then, on that selfish level, do you think if one of these patients that you're showing, despite your efforts, and you get their alignment spot on, and you do everything by the Bernstein book, do you think it's not going to heal if they keep smoking?
it may not heal. Yeah, it may not heal.
Yeah.
Yeah, I think it still may not heal. That's why I think we shouldn't be cavalier about the whole idea either, right? Like, there's a limit to what we can control and what we can do. And I think all of us are motivated and want to help people. So we want to give it that full go, but yeah, it may not work. And I don't think we still keep that in mind.
Like you said, we could talk about this all night. I mean, I have discussions with patients about decreasing their smoking or smoking cessation, but I will not get nicotine urine tests. They may smell like smoke, but I'm not doing any aggressive testing to make sure that they're compliant with our plan. Because usually they're not.
Yeah, if it's like a fibular non-union, yeah, we're not, I'm not running to do that. All right, so let me get through here so we get Steve on board. Problem list for me, varus is the biggest issue. Varus and rouleau infection, and the nail is broken, so that has some logistical implications here because you're gonna have a broken little piece in there. So intraop cultures, IM nail removal equipment, and again, I don't mean to mention your name again, Tim, but you did mention this, no toleration for varus. So really, we got to make sure that we eliminate the varus and make sure we can assess for that in the OR, because that would be the only thing that we're fixing here. I mean, it's a bit like femoral neck non-unions. It's a bit of a no-brainer, right? Like all you're doing is correcting the alignment. All right, good point, Mitch. No one's listening to me. Okay. So I did an open removal of the...
Sorry, Mitch, I was reading some of the Q&As. I was reading some of the questions and comments.
It's okay.
Looks like Dr. Warner is addressing some of them, so no offense.
Shout out to Jude decortication, because I have an open approach to remove the cephalmedullary nail. So I added a bit of a decortication, and I used a 3.5 DC plate contoured to help me obtain the alignment, maintain the alignment, and add compression to the tension side of the bone. I do not want to block the IM canal, and I need that cool hook to remove the broken IM nail, which was cool. Reduce the femur. So, and I have a push-pull screw here deployed for me to use at my discretion. And then I'm going to ream. I really want to do a full-blown shout out to I like to pause for a shout out to mentors, a full-blown pause and shout out to my mentors, because my mentors in Seattle at Harborview Medical Center taught me such wonderful basic things to use in an advanced fashion. And this is one of the things they taught me how to do. And so I want to reflect and mention my mentors. I thank my fellowship director, Dr. David Beret. So this is a 3.5 reconstruction plate from the pelvis set. It's very long, so you can hold it outside the wound. And I'm using the Reamers to push me to a medial entry point. I cannot use a lateral entry point, and I had a trochanteric entry, so I'm not going to use a piriformis. I mean, I'm not going to open the whole thing and put a piriformis nail in the canal. So this worked. This is my first time doing this. This thing worked. I mean, it was pretty awesome. Once the IM nail went in, I deployed the push-pull screw and killed it. Okay, I effing killed it. Now look at this at 8 months. This is why I chose this case for the webinar. Like, how biased were we with some of these patients who have such, quote, poor biology pre-op? So you could see the monster bone. I'm going to go through these for Stephen. The last point I want to just address, remember, the lateral cortex is on the tension side. We know the femur is eccentrically loaded. If you, in the subtroch region, you are furthest away from that axis, the varus will accentuate those forces and lead to high tension forces and likely a non-union. Similar with the other case that was really deformed. For me, recognize malalignment has implications in non-unions, and consider pre-op and intra-op strategies to realign the bone in addition to your stability strategies, there is no right implant or technique. I think we should stick to the principles and apply them.
Outstanding. Yeah, I mean, I think a lot of folks see a per-troch non-union, and the purists think blade plate every time. And I've done blade plates as well. And I love me a good blade plate now and again. But like you said, it's more about the techniques and the principles rather than the actual implant. But great cases. And in general, I will say I have had a similar bony healing response using that decortication technique. So
Yeah.
outstanding case. Great. Okay, Dr. Warner.
Fantastic. Well, continuing along the same themes, I like to kind of narrow things down with these complex problems of femur non-unions to think about why they happen, when do we intervene, and what do we do? And these are the kind of the three main questions we have to answer as we have with all these other cases. First case here, unlike Mitch, who doesn't have any losses in his career, I have several, so I will certainly present a loss here. This is the first case will be one of my losses. This is a 29-year-old high-speed MVC, has these injuries, which you can see here, bilateral humeri fractures, a forearm fracture, as well as this proximal femur fracture, and oftentimes will be salivating over these serrated transverse diaphyseal femur fractures because they are certainly a fun case to do. So this is a surgery that was done, piriformis entry, antegrade femoral nailing, locked proximally and distally. Mitch, any concerns with this? Would you do anything differently acutely for this injury?
No. What are those holes? You said it was an open fracture.
This was a
Open?
closed fracture that these were just chance pin holes used as manipulative reduction aids.
Okay.
So,
Okay. So percutaneous reduction.
Correct.
Okay. No.
So,
do I have any concerns? I mean, it's friggin' awesome.
So here is at 6 weeks. Again, he has these bilateral upper extremity injuries as well as some other intracranial injuries as well. But here he is at 6 weeks, just starting to get back to life after his polytrauma status. Here he is at 3 months and starting to get a feel for maybe this is not quite headed to the reliable union that we typically see with these types of femur fractures. And then 6 months here, looking
Steve,
at a bit.
I have 3 or 4 of these. Okay, I have 3 or 4 of these that resorb like this.
Steve, do you think this?
No, I didn't present.
This is a polytraumatized patient, multiple upper extremity fractures. Do you think there's something to the idea of, patients have a certain amount of bone healing units within their body, and this poor lady just maxed out her bone healing units? Like, does she heal everything else?
It's a great question. And I think that's something we think about a lot, is these bone forming units that patients may run out of when they have these multiple fractures. But interestingly, that you bring up that point, speaking to multiple losses, unlike Mitch, this patient developed non-unions of his bilateral humeri as well as his femur. So we had 3 long bone non-unions. That's a whole other topic. But so I think we get to this point here. We're at 6 months out. He's just starting to get back to life after his accident, and he has this left-sided femur fracture now that's starting to be symptomatic. And so we're getting to the point now he's in clinic, and we're trying to discuss what to do with this. And so again, trying to distill a complex a problem into something simple. This is just emphasizing what Dr. Akers showed at the beginning at the classification non-unions. The reason why this is important is because this can often dictate what we do for some of these complex problems. We can simplify it into this classification. This helps guide some of the treatment in general with hypertrophic non-unions to improve the mechanical environment, whereas in more oligotrophic, atrophic, we have to consider other things that may be improving the biological environment, then obviously with infections to be able to suppress the infection. Along the same lines as in this patient, considering why this happened. And so if we don't understand why this happened, then how can we understand how to treat it? And so in general, these are some 6 factors that we can think about, and these all have been reinforced so far during these cases, but 6 different factors that we can kind of consider for why non-unions can happen: instability, deformity, poor bone contact, and that a reduction probably wasn't done correctly, infection, inadequate vascularity, or some metabolic issues. And so for the case like this, you can pretty much come up with all of these, but these 4, I think, were ones that were sort of at the top of that list for these. And you may be looking at this and say, well, how is this deformity an issue for this this fracture? And if you really hone into the details, similar to what Mitch was presenting with the starting point and ending point for femoral nail being more along the medial spine of the tibia as opposed to the intercondylar notch. If you really look at this, you can see where the piriformis start site was initially more medial than the trochanteric tip. This certainly has drifted towards the trochanter as the non-union develops. Similarly, looking at the lateral cortex proximity to the nail, this also has a widened, suggestive of some increased varus, which is common with these non-unions as they develop. So you're sitting with this patient in clinic, and he just wants to know what we can do to make it better. And so, as we've mentioned, there's a whole lot of options that you can have to treat this. And just to engage the audience here, just as more curiosity's sake, these fellowship, all of you have gone through some trauma fellowship training. What would you all do for this 6 months out with this closed diaphyseal femur fracture that now is a non-union at 6 months? So go ahead and vote. You could wait, you could dynamize it, you can exchange nail, you can autograft with augmentative plating, you can do an exchange nail in addition to that, or you can.
They won't let me vote.
You can't vote. The hosts and panelists cannot vote.
I know, but I'm curious because this is a big challenge.
As everyone is putting in their vote, why don't we close that poll and see what the answers were. So fantastic. We got a smattering of answers ranging from, so not many people want to wait. Most popular being kind of the kitchen sink, as we call it, the exchange nail, autograft, and plating. Fantastic. Dr. Aker, when you're sitting in clinic with these patients, this is obviously a big part of their life right now, and they're just coming back from a serious injury. How do you talk to them about these different scenarios and the different invasiveness of these surgeries?
Yeah, I mean, like all surgeons, I treat patients, not X-rays. So we've all had patients with this X-ray that are just getting back to work, and they work down at the AutoZone, and they might have to carry a car battery out to the parking lot, but otherwise, like, it hurts at the end of the day, but they're fine, and they're finally paying their mortgage again, and they're not divorced yet, and hallelujah, and they really want nothing done. Other patients with this X-ray are absolutely miserable. So it really depends on the clinical scenario, on where I might help lead the next operation.
Mitch, anything else to add for these discussions you have with patients in clinic with these issues?
I mean, there's I don't know, I'm stuttering. It is attractive for a repeat percutaneous surgery. So, you know, as soon as you indicate them for plating, obviously it's an open approach. The exchange nailing is percutaneous, and I think there's a lot of advantages for that. There's some practicalities with same-day surgery, especially post-COVID and bed logistics. I mean, those are things I really talk about. So this is really hard, Steve, to be honest. And again, like, how do you know it's infected? Am I like changing the topic here? And because, like, how do you know?
That's a great question.
I know you don't know. I'm not trying to be stupid, but like, how do you, like, you know, does it matter if it's infected? Are you taking reamings? Like, if you're doing exchange nail, do you take the reamings that you never get and then you sort of put them in the jar?
In the jar.
And
that's a great question.
Epi?
Yeah, it's 1 out of 4 staph epi, you know, that comes up. And then what do you do with that? You get a PICC line and the complication for the PICC line or the antibiotics. And then, you know, is that worth it? So I think, you know, in terms of the infection, I think the pretest probability is something that's important. And so looking at what are the chances that a closed femur fracture that underwent intramedullary nailing is infected, it's fairly low, but, you know, that being said, it's possible. But with the history of no open wounds, no problems healing, no systemic symptoms, I think that all goes into that equation. But nonetheless, like you said, certainly possible with some indolent infection causing this.
The only comment I'd go back to, Steve, if you go to your injury X-ray, you didn't, if this was opened, because you didn't circle vascularity as one of the options, but with that amount of recoiled displacement and shortening, if that was open, you'd be staring at, during your debridement, you'd be staring at a naked femur. So, we all know the amount of energy it takes to make an open femur, and that's why these holes are tiny, because the energy just peters out past the IT band. But I think soft tissue stripping is a huge thing here, especially because your reduction is anatomic. So I don't know what you can do for that, but that's what I'm thinking about.
Yeah, it's a great point. I mean, all these factors can certainly come into play, and so not to belabor the point, I think there's a lot of ways you can treat this successfully. But I thought this case brought up a relatively interesting algorithm that you can think about for treating these patients. And as Dr. Aker said, each patient is different. The conversation is really a shared decision making with the patient regarding where they're at with their symptoms, where they're at with their life, recovering from these injuries. And so with this patient, he elected to go for the most percutaneous surgery. He wanted something done, but actually this was done during one of his humeral non-union surgeries. And so that played a factor into this decision making. And so we did a dynamization, as you all know, is where you remove the interlocking screws, and that changes the mechanics of the fracture. The goal being that hopefully the change in the mechanics of that fracture would also change the biological stimulus around the non-union. And so here he is. You can see him follow-up in 3 months. And what you can see in that distal femur X-ray is that he compressed about 4 millimeters or so, comparing where the interlocks were with where the nail is now. And then what you can see is the response of the non-union to that, from a relatively oligotrophic non-union to now more looking like a hypertrophic non-union. And so as we go back to this classification, we've converted the classification to something that's more hypertrophic, which we then can change some of our treatment algorithm for this patient. So now we have this here. And so we're at the 3-month mark, and he's recovering well from his humeral non-union surgery. He's now asking, what can we do to make his leg feel better? So Dr. Aker mentioned the success rate of exchange nailing for diaphyseal hypertrophic femoral non-unions, and being a relatively percutaneous surgery.
That are well aligned.
Correct. That are well aligned. A very good point that you'll see and hear during the course of these cases. So just not to belabor the point, you all know the principles of exchange nailing, but it's important to keep that in mind. The selection, you don't want to just exchange nail everything. You need to have some cortical contact. You want to increase the diameter of that nail. You want to have some progressive reaming with the thought that stimulates the periosteal blood flow or perfusion to that non-union. A different nail manufacturer can help with getting native bone for interlocking screws. In general, static interlocking to improve the stability of the non-union. And then, as Dr. Aker mentioned, improved alignment is often forgotten component of this, and it's probably I think the hardest part of these cases. And you can get into the whole other talk of how to improve alignment of these non-unions, especially with exchange nailing. Some techniques that you guys have already seen in these cases that were presented by Tim and Mitch are changing the nail geometry, changing the start point, changing the end point, adding blocking screws. So all those are important ways that you can change the improvement. You can change the alignment of some of these non-unions. So that's what we did for this patient. We altered the geometry of the nail, creating hopefully improving his alignment using a trochanteric entry nail. So that previous piriformis start site that is now since lateralized due to the deforming forces on that proximal femur. And this was his end result here at 6 months after that exchange nailing. So whereas something that may have looked daunting at that 6-month mark from a non-union standpoint with some relatively percutaneous surgeries, was able to get it across the finish line. So maybe not the most reliable algorithm for some of these, but certainly something to keep in the back of your mind again, depending on the patient situation.
It's really a good case for what you described, his clinical symptoms. He's finally starting to, a polytraumatized patient 6 months in is finally starting to feel like themselves. Yes, his leg hurts, doesn't really want to do much. I will say that exchange nailing of image 2 here, this is not a slam dunk. You know, the title of this webinar is how to get it right the first time. You can exchange nail this and you might have success. But I'd say the odds are not with you unless it's hypertrophic and well aligned, which you've gotten them there. You've kicked the can down the road and prepared yourself for success. So great case.
I would like literally 45 minutes to unpack this case. I mean, this case is so cool because, you know, I've never seen this done. I think it's so intelligent. If like moving from you know, dynamizing the nail and then responding to sort of reverse dynamization. We talk about that with our ring fixators now, and stiffening the implant versus just leaving it dynamizing. You did a full-blown exchange nailing, because I wonder if you considered just adding interlocking screws to the dynamized nail as opposed to exchange nailing. I mean, you clearly, like, if you look at the end result, you're like a bone biologist. I mean, you generated this callus, this strain environment that's wonderful. I mean, it's a crazy case, Steve, because I agree with Tim. Like, I've exchange nailed these cases and maintained that gap with a larger nail like a moron, and it's like what are you doing? What am I doing?
Yeah, I think it's just something that, you know, again, you can treat these a number of ways, but I think there's more ways to do these. And I think just really thinking deeply about the non-union and why it's happening and all that, I think it's important. Real quick here, one last case, a little quick hitter. 24-year-old MVC with this distal femur fracture, initially treated elsewhere with this retrograde intramedullary nail as shown here, and then referred to clinic at 3 months for this excruciating knee and thigh pain. So, Mitch, what are you thinking here? She's 24. She works at a grocery store. She just wants to get back to work. She's genuine about that, and she's pretty frustrated right now. The treating surgeon just wanted to kind of shorten some of those interlocks because they thought that may help with the pain. But is 3 months too early to do something? But before you answer that, again, we're going to get a quick poll here while you're thinking about that, because I would love to hear. I would love to hear. You're not going to be allowed to. You're not going to be allowed to vote.
I honestly am still thinking about the last case. I'm in like.
Mitch, it's time to move on. We only got like 10 minutes left, so we got to move on.
I can't move on.
But here's some options here. We can wait. You know, there's a comment in the Q&A box about what you consider non-union. It's 3 months too early to consider non-union. Again, we can go through all these other options: dynamization, exchange nailing, kitchen sink with exchange nail autograft and plating. Maybe this would be a good case for just compressive plating once the nail is out. So lots of options. Go ahead and put in your vote. Let's see what people want to do. Awesome. Great smattering as well. Based upon the last case of a lot of exchange nailing, there's some exchange nail autograft plating. There's some nail removal and compression plating. So lots of good choices here. So Mitch, what do you think?
So like quickly, right? So it's awkward. It's 3 months. That's really awkward situation. So I'm going to, we're going to be honest here. It's a simple fracture line, goes to direct reduction techniques, absolute stability construct, plate and screws, but that's potentially not so easy to do at 3 months. There's a lot of like debridement of tissue to get that done. So I'd be thinking more about IM nailing. I'd have to work her up for deformity. And then you're playing around with entry point trajectory in the distal femur plus blocking screws on the medial side because it's in varus. And then you really need to maintain that alignment and kill it. So then you're going probably for an open reduction IM nailing That's what I would do. Open reduction, I am nailing. I have no experience with this nail. It makes me a little nervous. And at 3 months, it's like awkward. I probably want to wait another 3 months, to be honest, and then I pull the trigger on that. Open reduction, I am nailing with a more standard longer nail for me with 2 distal interlocks, 2 proximal.
Aker, she's begging you to do something. Would you do anything at
Yeah.
3 months? Or would you wait?
This is a tough one. And, my own personal bias is that exchange nailing works in the diaphysis for hypertrophic non-unions. In general, it doesn't really work so well in supracondylar distal femur fractures. Exchange nailing is not the first line of treatment for this problem. The good news is it's not really a non-union. She's just miserable. You've just met her. So I would agree that with some improved alignment and re-reaming, blocking screws to stiffen up the construct, exchange nailing can work if she's looking for something more minimally invasive, but otherwise.
But you can't do an in situ exchange nailing, Tim. You agree? Or could you? Or I mean, you have a diaphysis, so you can control your. I mean, are you going to try to realign that?
Well, with a nail.
Yeah, with nail. Like
Yeah,
when you
this is
say
like that.
exchange nailing, you're realigning.
Yeah, I think that goes without saying. I hope
Yeah, okay.
they got the point with earlier, either the drilling, how mobile is it, the blocking screws, to your point, but this has to be better aligned if it's going to work with a nail.
I mean, the other thing I would do, Steve, because I feel like I'm being pressured to do something now, is I would get the alignment X-rays at this clinic visit, and if it is malaligned, I would indicate her for surgery tomorrow based on the malalignment and not necessarily that it's going to go on to a non-union.
Got it. No, that's all
Oof.
fantastic points. I
Feel
think for
better,
me,
lad.
yeah, deep. I think that's a great point. I think it's important to have the patient not necessarily suffer, but at least prove to you that they're not going to go on to Helix without surgery. So I think giving them some time is important, but and seeing the trajectory of pain. How are you doing 6 months ago? How are you doing 2 weeks or 6 weeks ago? How are you doing 2 weeks ago? Is that trajectory improving at all? Is it getting worse? Is it staying the same? I think that's all important, not just clinically, but radiographically. So, and I think going back to the similar points of why this happens, I think you could pick out a number of different points about the stability, the deformity, the pore bone contact, the pore bone reduction, potentially infection. Vascularity certainly could be a factor as well, and metabolic issues as well. And so we waited some for her, another 6 weeks, and she got worse, more miserable with unchanged X-rays. And so we took her to the operating room, removed the implant. Don't forget the end caps. If it's done by someone else that can maybe put them in. Again, similar to what you guys have seen with all the other cases, confirm the non-union mobility. You want to make sure you can realign this non-union. It was relatively stiff at this 4.5 month mark. And so, as was described previously, some percutaneous techniques to be able to mobilize the non-union to correct the deformity. And blocking screws are your friend with trying to correct these deformities in a percutaneous fashion, which can often be done in exchange nailing, again, which can be beneficial both from a biological as well as mechanical environment standpoint.
I like the blocking screw on the proximal fragment in this case, Steve, based on the pre-op X-rays so I like that. That was smart. That's a subtle move. I think that's smart.
Yeah, you have to be careful. This was, as you'll see in the post-ops, it's a little aggressive. There was a little propagation as that nail went up there, but I think with 24-year-old good bones, certainly I think was able to hold.
I agree though with that, right? Like as you get aggressive with these blocking screws, you got to be careful that something else doesn't give, like your entry path, etc. But that is perfect execution. Wow, that's good.
I think at this point, though, you look at these, and as Dr. Aker said, this is definitely not a slam dunk. You look at this, and you're like, I don't know if this is going to heal. I think, but given her age and the lack of other comorbidities, I think that's another factor that you can use to potentially comfort you that this has a chance now with increased stability, with a longer nail, improved alignment, improved bony contact. And so here she goes on to heal at 9 months and is back to it. So Again, another technique for a different type of non-union that can be done. Again, you saw some other cases with more open techniques. Here are some examples of what can be done, improving the alignment percutaneously and then getting these to heal. So, Dr. Raker, I turn it back over to you for the last 5 minutes here.
Well, those are all outstanding cases. And to Mitch's point, I mean, really, any one of those cases, I feel like we could just spend all day talking about. I did see there was a couple comments about statically versus dynamically locked nails, and whether or not a statically locked nail that ultimately gets a little bit of resorption. Mitch, had it been dynamically locked to begin with, do you think perhaps that could have been avoided?
I think so. You know, I think that there are other places in the world, I think, that do that more routinely. I had a patient from France who had a distal third tibial shaft fracture. The nail was placed and there was one locking screw distally from anterior to posterior to capture the posterior malleolus. I was freaking out because I had to speak to my partner because I'd never seen it before. Went on to heal wonderfully. So yeah, I think that I think I'm doing a disservice to some patients who need that dynamization. I just don't know who.
Steve, do you think that in that transverse, very high strain environment, transverse subtroch, has your practice changed at all? Are you dynamically locking proximally for those, or do you still? I mean, your reduction, you can't argue with it. That was spot on, osteocyte to osteocyte. But then as it resorbs, I mean, should we be dynamically locking those?
You know, I look back at that and I almost think there was not enough stability. You know, there's one oblique interlocking screw proximally. Maybe that was the problem. Maybe there wasn't enough stability. Maybe I should have put 2 screws proximally because of all the forces on the proximal femur. I think this question of what is the optimal fracture motion that's required for bone healing is something we don't have a good handle on, and it's hard to measure. Every fracture pattern, every fracture location is going to be different, and so that's certainly something that I continue to wonder about and don't have a great answer for.
Well, I sure am honored to have had the opportunity to hear you guys talk about those cases. I mean, some of them, like Mitch said, very thoughtful. We have Dr. Warner, the bone biologist, making bone out of fibrous tissue just by changing the biomechanics. For a lot of these cases, yes, you can exchange nail. Yes, you can just add an augmentative plate. You can add a plate and bone graft. You can add a wave plate. You can do a nail plate combo. There's a lot of options, but I think if you really identify the type of non-union, the local biologic milieu, how much biology is present, if there is coronal plane or sagittal plane deformity present, all of these preoperative factors have to go into your decision making to what might help you get it right the first time, rather than just exchange nailing it and then looking in the rearview mirror and wondering why that didn't really work so well. So with that, I mean, I hope we learned a little bit more about techniques for classifying non-union. We really talked about the importance of the preoperative evaluation. We certainly talked about a variety of effective treatment modalities. And I know now I certainly understand some new technique of outcomes for femoral shaft non-unions. So thank you, Dr. Bernstein and Dr. Warner. That was a fantastic. I wish we had another hour to chat here. Really, I do. That was awesome. I'll remind all the fellows that we have plenty more webinars coming up, as you can see here, whether it's proximal humerus, distal tibia, distal humerus, or pelvic fractures. So hopefully those are all on your calendars. And then for all AO members that are joining, including fellows, there is the North American webinar series, again, Tuesday nights at 8 p.m. monthly. You can see the webinar series as listed here. Go to aona.org to register or for more information. But man, that sure was a lot of fun. I can't wait to do it again. Thanks for all the participants for joining us tonight. Thanks for all your questions. Sorry we didn't get a chance to answer all of them, but man, that's a lot to unpack there in an hour. But thank you, Mitch. Thank you, Stephen. And see y'all next time. Appreciate y'all.